And welcome to the Dr. Bob Show. Could you have heart disease and not know it? Are you at risk for heart disease and don't know it? Cardiovascular disease is the leading cause of death in the United States. Do you have symptoms of heart disease and don't know it? Are you a candidate for heart disease and don't know it? We'll be spending most of this show talking about risk factors and what early symptoms of heart disease are and what you can do about it. My guest is Dr. Malcolm Foster. Dr. Foster is a board-certified cardiologist. He'll be answering our questions. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about those spots on your skin. Could they be something dangerous? We'll talk about that. And the difference between diverticulosis and diverticulitis, a lot of difference, and it'll mean a lot of difference to you. A lot of information for you. You'll want to stay tuned. We're talking with Dr. Malcolm Foster, board-certified cardiologist, and we're talking about how do I know if I've got heart disease? Malcolm, welcome to the Dr. Bob Show.
Thank you, Dr. Bob.
You know, it's a common question that people have. Do I have heart disease? Is my heart in good shape? Where do you tell people to start? What should they do?
Well, heart disease is very common, particularly in middle-aged and older adults. So generally we say start with your primary care physician and have a good history and physical exam.
And for the history and physical, you'll get an indication of whether you meet some risk factors. What are some risk factors when we use that word?
Right, so some of the more common risk factors are things like high blood pressure, high cholesterol, high blood sugar or diabetes, and smoking.
So all four of those. Now, what's a normal blood pressure?
So normal blood pressure, 120/80 or lower.
And so that's the number that people ought to remember. If their blood pressure is high, I always recommend they get a blood pressure cuff at home so they can measure it, so they can help their doctor know what their blood pressure is. Cholesterol, what's a normal cholesterol?
So a normal cholesterol is certainly under 200, but really ideally it would be under 150. And then we look at the good and the bad cholesterol. So the bad cholesterol, that's the LDL, we want that to be low. And the good cholesterol, the HDL, we want that to be high.
Are there medicine? How do you get the cholesterol, the LDL, to be lower or the HDL to be higher? What do you have to do?
So we recommend, first of all, healthy lifestyle. So we recommend healthy diet, healthy exercise, keeping your weight down. But then to lower the bad cholesterol in particular, we have a very common medicine called a statin drug. And
those are wonderful at lowering that cholesterol.
They are.
Are lots of cardiologists on statin drugs?
Most of them.
Yeah.
Probably 90% of cardiologists take statin and an aspirin, a baby aspirin.
You know, and I'm on a statin too. My father had high cholesterol levels, had hardening of the arteries, and so I just didn't play around. I started on a long time ago.
Yeah, very smart.
And so blood sugar?
Blood sugar. So a fasting blood sugar should be under 100. And what we used to call borderline is really a mild case of diabetes. Most of that diabetes, though, is called type 2 diabetes, and that can oftentimes be corrected with exercise and weight loss and dietary changes.
Type 2 diabetes, diet control sometimes, still a risk factor for heart disease, though.
Yes, it's a major risk factor. In fact, we call it a heart disease equivalent.
So if you've got type 2 diabetes or diabetes of any kind, you need to pay attention to it, get that under control.
Very much.
How about smoking?
So no smoking is good. No smoking, even so cigarette smoking or really smoking of any kind. And we do everything we can to help our patients to quit.
So the other things as far as risk factors would be, how about inactivity, sedentary lifestyle, obesity? Are those risk factors?
They absolutely are, yes.
And how about age?
Right, so age actually is not modifiable. You know, year by year by year, we gain that risk factor, and that is certainly a risk factor. That's why I say with middle age and older people, we see more and more heart disease.
So if we look at our risk factors and we have a history and physical by our primary care physician, we can begin to guide a lifestyle to where we can hopefully not have heart disease, that we can prevent heart disease. Let's talk about coronary artery disease. Now, first of all, what are the coronary arteries?
The coronary arteries are the heart arteries. They supply blood flow to the heart.
And of the coronary arteries, how do they get diseased? What happens to them?
Well, those risk factors that we just discussed are risk factors for the development of plaque buildup or atherosclerosis. So atherosclerosis is plaque buildup or blockage of the coronary arteries.
When you get plaque buildup on a coronary artery, does it produce symptoms?
It does. As it gets more and more severe, the person can suffer angina. And angina means lack of blood flow to the heart, where they may have heaviness, pressure, tightness, squeezing in the chest.
When somebody has that, what do you do for that? Work on their cholesterol more, work on their blood pressure more, work on their lifestyle more? What do you do?
All of the above. I briefly said blood thinner. So blood thinner is usually very important. At least a low dose of aspirin, baby aspirin. Sometimes we treat more intensively. But then we work on lifestyle and lowering that cholesterol, lowering the blood pressure. If that's not enough, then we may have to go and treat the person more aggressively for that plaque buildup.
So if somebody has plaque buildup, if they have angina, if they're having symptoms, how do you find out how bad it is?
So we typically do a stress test. So if it sounds like that they're having angina, what we call stable angina with exertion, we'll do a stress test, and sometimes with a scan or an ultrasound of the heart to see if it's a high-risk scan, see how much of their heart is affected by the blockage.
So you can frequently tell with those tests. If you feel like there is a lot of potential danger, potential blockage, can you do a cath at that time? Will that give you more information?
Oh, absolutely. So the gold standard really is a heart catheterization or an angiogram, and that's where we put X-ray dye into the heart arteries.
And what does that show you?
So that shows us in great detail the blockage. So it shows us if there's blockage in the coronary arteries, calcium buildup, and how severe it is very precise, and helps us to determine if somebody might benefit from a balloon or stent, or perhaps even bypass surgery.
So the indications for that would be if the cath was abnormal, you figure out how abnormal, and then you decide what type of treatment to use?
Right. And if we're going to do a stent, we typically do that right at the same time. Bypass surgery would be later.
Now, when you said somebody has coronary artery disease and they have angina, they have a pressure pain in their chest, is that worse with activity?
Yes, if they have a classic example of it. Not everybody has a classic symptoms. Particularly women may not have chest discomfort at all. They may have more nonspecific shortness of breath, fatigue, indigestion, and not realize it's their heart.
So what is the difference if somebody's having angina from the big one in the sky, from somebody that's having a true heart attack? Do they have the same symptoms?
Well, angina symptoms, if you're having a heart attack, then that is chest discomfort that does not go away. It's more severe, it tends to be more severe, and it doesn't come and go with activity, it comes and stays.
And so if somebody has a heart attack, what do you tell them to do?
We tell them 911, call 911, don't have your spouse bring you in. It's better to call the emergency services.
Because emergency service will have oxygen available, portable electrocardiogram, they can get the information ready as you're getting to the patient.
Correct. And sometimes they have to defibrillate.
A defibrillate would be what indication for that?
If the heart goes out of rhythm with that heart attack.
So when they go to the emergency room and they've got a heart attack and they make that diagnosis with the electrocardiogram or what's available, you go to the cath lab again then?
So if it's a heart attack, we go very promptly to the cath lab immediately.
And why do you do that?
We say time is muscle, talking about the heart muscle. So the more quickly we can get to the cath lab, the more quickly we can open the blocked artery and save that heart muscle.
So in your experience, if somebody comes in with a heart attack and you take it up to the cath lab and you open up some of the vessels, how much, how often, how frequent do you get the good results where the patient doesn't have as much problem?
Well, it's most of the time. Most of the time. Our success rate is very high, particularly if people come in promptly. Now, if they had the heart attack and they show up a few days later, then the results are not going to be as good.
Okay. Other heart problems, do people have sometimes fluttering heart?
They do. It's very common.
And that's what we're going to be talking about when we come back. We're going to be talking about other types of heart disease. Rhythm problems. Do you have a rhythm problem? Could you even have heart failure and not know it? We'll answer those questions when we come back. We're talking with Dr. Malcolm Foster, board-certified cardiologist. How do we know if we have heart disease? Well, first of all, see your doctor. Second of all, do you have risk factors? Are you a smoker? Stop. If you have high blood pressure, get it under control. Diabetes, if your blood sugar, fasting blood sugar is greater than 100, you need to get that lowered. And if you're obese, you need to work on getting your weight properly, and you need to be active. So with those things, you can control some risk factors. If you do have coronary artery disease, the coronary arteries supply the heart muscle its blood. You can get angina. That's a discomfort, a pressure discomfort. Or if you have a heart attack, that's usually a crushing chest pain, sweating, you know something's going wrong. 911, get to the hospital because time is heart muscle. Now, Malcolm, what if somebody has a fluttering heart, or they can feel their heart, or somebody says, I can tell my heart's pounding? How do you, when you hear that from a patient, what are you thinking about?
So with that, we think about arrhythmia, or irregularity of the heart rhythm.
So what are some of the rhythm problems that somebody may have if they come in?
So most of the rhythm problems are relatively benign, meaning you don't die or have a catastrophe, but it's extra heartbeats that might come from the upper chamber of the heart or the lower chambers of the heart.
How do you know if it's coming from an upper or lower chamber? Is either one of those more problematic than the other? Do you find this on the electrocardiogram?
So we usually start with an electrocardiogram or an EKG, and that gives us about 10 seconds in time. An EKG does. Otherwise, we may do a longer monitor, and we'll monitor somebody for 24 hours or even 30 days, and that can show us the rhythm abnormalities.
So what are you looking for that would make you nervous? If somebody's got extra beats from the upper chamber, lower chamber, atrial extra beats, ventricular extra beats?
Right, so the atrial are from above and the ventricular are from the lower chambers. The ventricular beats are more concerning for us, particularly if somebody has a history of heart disease or a heart attack or a weak heart, then those extra ventricular beats can be more of a concern.
Do you ever pick up a run of abnormal beats? Does that make you worry even more?
It does. It does. And the longer and the faster and the longer, that's more severe.
How about people that suddenly get a rate of 150 to 170? I think SVT. What does that mean?
Mm-hmm. So that originates from the upper chambers, and that can happen to young, healthy people. That does not necessarily have to do with heart disease like blocked arteries. But it's an electrical problem, and that can oftentimes be treated either with medication or with a procedure called an ablation.
So those can get rid of the upper chamber fast heart rate.
Yes.
How fast is that heart rate usually?
Well, so a common one will go at about 150. That's called atrial flutter. And there are some that are SVT rhythms that will be 180 or 200. And that's really flying. The person feels it.
So if the heartbeat is 150 or 170 or 180, does the heart not have time to get a forceful pump, and what symptoms does the patient have?
Right, so the person feels racing of the heart, palpitations, racing of the heart. Sometimes they'll be lightheaded and they might feel like they're going to faint.
So if somebody has an abnormal rhythm like that, medications, and then would you put that something to record their rhythm to make sure it's working?
We do. We can even place an implantable loop recorder under the skin, and that's very helpful for a longer term recording. Records up to 3 years.
Can you think of what it's like practicing now versus practicing 20 years ago when you didn't necessarily have all of these things?
Right.
It really makes it where it really helps the patient. How about other rhythm problems that we see frequently as people get older? Atrial fibrillation, what is that?
It's very common. That's when the upper chambers no longer have organized beating. So lower chamber, upper chamber. The upper chambers just wiggle. They wiggle, and that's what we call fibrillation. And it's fairly common. We see it as people get older and also with some risk factors like high blood pressure.
So if you've got atrial fibrillation, what do you do?
Well, one of the most important things with atrial fibrillation is the person needs to be assessed for blood thinner because there's an increased risk of blood clots.
Why is that?
Because the atria are no longer pumping and that blood is a bit stagnant in the upper chambers.
So it's the upper chamber that can get the blood clot
Yes.
that flips it up to the brain.
Right, so that blood thinner is very important because it prevents stroke. And that's number one of importance. Other things are whether or not to be on medications. Sometimes there are procedures. And so there's a variety of ways to tackle the problem.
So tell me about ablation. What would that be? And would you ever use ablation in atrial fibrillation?
We do. So ablation is there to interrupt that extra heart rhythm, and it's a catheter procedure. It's to interrupt the extra heart rhythm, and it has a pretty good success rate.
So if you have an ablation and it's successful, the heart rate's normal, and you can get off your blood thinner?
Perhaps. We have to observe you for a period of time.
So it's always a problem that it might come back and cause
Right,
problems
it might come
like
back.
that.
Mhm, yes.
So chronic atrial fibrillation, what is the rate normally with that?
Well, it varies. We oftentimes give people some medication, like a beta blocker or calcium blocker, to slow the heart rate down. But chronic atrial fibrillation can have a fairly normal heart rate in the 70s, say, and that would be very acceptable.
So we've got rhythm disturbances. Tell me about heart failure. Does that mean the heart stops?
It doesn't stop, but that forward flow does not work as well, and there's some congestion. And congestion is back to the lungs. And that's the idea of being congested, fluid buildup, short of breath.
And when you get the buildup, well, how do you treat it? What do you do for heart failure?
So we can use a type of medication called diuretics, and diuretics stimulate urine output to get rid of excess fluid.
So it doesn't put as much load on the heart if you don't have as much fluid.
Right.
Anything to strengthen the heart muscle?
We do. We actually use the medication that I mentioned, beta blockers, and we use other types called ACE inhibitors and ARBs, and that improves the forward flow of blood flow out of the heart.
So the early symptoms of heart failure would be what?
So the early symptoms can be fatigue and exercise intolerance, where you have to stop, you can't do the types of activities that you normally do, shortness of breath. As it progresses, you have trouble lying down, and you may have fluid buildup, not only in your lungs, but in the rest of your body.
You get edema of the legs?
Yes.
How do you detect edema?
Well, we can do it by examination, so we can listen and examine the patient, and we have very good blood tests now that tell us that, called a BNP blood test.
And the BNP blood test can really tell you if you're in heart failure?
It's very helpful, yes.
And the medicines help control it, and you have to keep in contact with the doctor to be sure that the heart's functioning well.
Very close contact, yes.
Anything new in heart failure and heart rhythm problems?
Absolutely. So we have new medications that have been very helpful. I mentioned this ACE inhibitors and ARBs, and they're called ARNIs. So it's a new class of medication. They're even better. And we have new devices like defibrillators, pacemakers, defibrillators. And we have monitors that can be implanted to monitor pressure within the heart and the lungs.
Amazing what is being done from a heart standpoint, from the cardiologist. Malcolm, you all are wonderful. I can't tell you how many lives that you all save and the stories that I hear of people that have done so well under the guidance of a cardiologist. Thank you for coming to the Dr. Bob Show.
Thank you very much, Dr. Bob.
Well, wonderful discussion. If you've got heart symptoms, be sure and work those out with your doctor. Be sure you get adequate treatment. If you've got rhythm problems, know that there are medicines. If you've got heart failure, there are medicines. If you've got angina, there are medicines. So much that we can do. If you've got risk factors, take care of them, stay healthy. And now you're going to want to stay tuned because we're going to be talking about those spots on your skin. Could they be cancer? What are some of the signs that we see of skin cancer? And also the difference between diverticulitis and diverticulosis. A lot of information for you. I want to thank Dr. Malcolm Foster. Wonderful discussion on how do I know if I've got heart disease? And now questions from you, the viewer, that I think will be important to your health. Question number 1, Dr. Bob. I have different colored spots on my skin. Should I get worried? Well, it seems like the older we get, frequently spots will pop up. And we get worried about, could they be cancer spots? So let's talk about some of the skin cancers, and let's talk about how to recognize them. The cancer that we worry about is melanoma. Melanoma is a little brown spot that can occur anywhere on the skin. More frequent in people that have been exposed to lots of sunlight without sun protection. Be sure and wear your sunscreens. So a melanoma is a little brown spots. There's A, B, C, D, E of melanoma. The A is asymmetry. So it's a little round, dark colored lesion. If it's symmetrical, nice and round, then it's probably not melanoma. But if it's irregular like that, there's a greater chance that it may be something abnormal. So that's the A. The B is the border. The border on one side is different than the border on the other. So if you cut it in two, you couldn't lay them on top of each other. So that's the second one, asymmetry and then irregular borders. C is the color. The color of melanoma can be different colors in the same lesion. It could be brown, it could be red, it could be bluish, it could be raised or flat, it can be any of those. So if the color is different in different parts of the lesion, you need to think of melanoma. And D is the diameter. The diameter is 6 millimeters. 6 millimeters is about the size of the end of an eraser on a pencil. So that's the A, B, C, D. E is evolution. If that little spot changes, gets bigger, starts changing in its color, changing in its size and its irregularity, then that's a sign you need to immediately see your doctor and get that taken care of. Now, there's lots of other spots that will pop up on the skin. And I think it's always a good idea to have a dermatologist in your repertoire of doctors that you see so that you can get a skin check. You can always look at your skin in the mirror, but you can't see our back too good. And so we have to be careful of common places for a melanoma to pop up to where you can't see them. There are other skin lesions, basal cell cancers and squamous cell. They have a different characteristic than does the melanoma. Question number 2. Dr. Bob, what is the difference between diverticulosis and diverticulitis? My doctor says I have one, and it may lead to the other, and I need to know what I should do. Well, at the end of the colon, there are frequently little outpouchings. Those are diverticulum. They're very, very common, and we call that diverticulosis if you have several of those little pouches. Now, if for some reason those get inflamed or infected, that's diverticulitis. Much different problem. Diverticulitis usually has pain, sometimes fever. Sometimes you can actually get fistulas. That means from the inflammation of the colon, it can cause a little fistula, a little outpouching, a little tunneling of infection to go to other parts of the colon. It can be very, very dangerous. You have to be treated appropriately by your physician. Usually it will require antibiotics and rest, and you'll be placed on a diet that helps control colon activity. So diverticulosis, very common. Diverticulitis, something you don't want to have, but if you do have, it's a treatable entity. So be sure if you're having lower abdominal cramping pain, diarrhea, and some blood in your stool, if you're having those things, you need to see your doctor. He'll be able to do a colonoscopy. He can tell if it's just the outpouching, if it's the diverticulosis, or he can tell if there's inflammation where you have diverticulitis, where you need more aggressive treating. Diverticulitis can certainly be recurrent. It's a problem that once you get it, you need to be in touch with your doctor so that when you get symptoms, you can begin to treat that early. Well, that's all the time that we have for this show. Remember, those 4 things we like to do. Number 1 is exercise. Probably the most important thing you can do is exercise on a regular basis. Sometimes we give too many excuses. But you can get out in the water, you can go for a walk, you can go on a hiking trail, you can ride a bicycle, you can get those tennis shoes out and even go jogging. When you exercise on a regular basis, and that's 150 minutes a week, then it will reduce stress. It'll help you lose the weight that you want to lose. It'll make you feel better. There's a runner's high. There are chemicals that come out of the brain that will make you feel better. Eat properly. You know, we are what we eat, so be sure that we eat good foods. Fruits, vegetables, less red meat, less fatty foods, less fried food. When you sit down to eat, look at your plate, see how much your stomach really needs. Cut down on your portions if you need to lose some weight. And that 7.5 hours of sleep, how great that will make you feel. If you're not sleeping well, talk that over with your doctor. Know that sleep is very important for your health, and when you don't get a good night's sleep, then it can lead to other health problems. And most of all, what is it we like on the Dr. Bob Show? It's that laughter in your life. You know, the more you laugh, the healthier you're going to be. Find that person, tell funny stories, laugh a lot, giggle a lot. People around you will be happy, you'll be happier, you'll be better, and you'll be healthier.